All right, the next talk will be about glenoid and scapular fractures, surgical indications. Dr. Kandemir.
Okay. Thank you, Mal. So I'm going to switch over here because I'm height challenged. Okay, I'm going to talk about glenoid and scapular fractures, and later in half an hour I'm going to show you some videos too. Is there going to be a good continuum? So this is a patient that shows up. A lot of scapular and glenoid fractures, we think that they are not surgical. This is a 75-year-old patient that showed up in my clinic about 3 weeks later, and obviously I operated on him, and I'm going to try to tell you that when you need to operate on them. Actually, this fracture has been known for a long time and written about it for a long time, as you can see. Even the fracture patterns are very well described, including the acromial base or spine fractures or associated fractures like proximal humerus fractures by Malgain long time ago. They are associated with a high injury because it's hard to break the scapula. There's a large mass of muscles and it's kind of in the center of the body. It's not easy to break the scapula. To break your scapula, there are other things usually get injured, especially ribs, clavicle, or they have usually, as you can see on this axial CT cut, hemopneumothorax too. 50% of the time they have some ipsilateral extremity injuries or C-spine injuries, or a lot of them have some brain injury too. There are a bunch of classification I don't think anybody really uses other than research purposes, which there's not much about it. Basically, you describe the location. The main thing is like, is it involves the glenoid, or is the body, or any basically displacement of the neck? That's what you need to know. Indications-wise, this is probably the most important slide of this talk, and I'm going to repeat this one more time at the end of the talk. So in the green box, as you can see, is more consensus about it. So when there is a glenoid fracture that causes an instability of the shoulder joint, mainly glenohumeral joint, or there's an articular step of 3-4 millimeters. Again, you see 3-4 millimeters, which we don't accept in other joints. There are several reasons why we accept here 3-4 millimeters. I personally don't accept 4 millimeters in young, healthy patients. Glenopolar angle is also relevant for the position of the glenoid. If it's less than 22 degrees, it may be an indication. Again, is under the yellow box, so it's a little controversial. In the body, if there's a lateral body offset of 2 centimeters, body angulation of 45 degrees, or there's a significant displacement at 2 parts of the shoulder more than 1 centimeter. And I'm going to show some pictures how to measure this and what they mean too. So we are looking for deformity. What are the significant deformities? Again, one is the instability, as I told you. Instability means that anterior inferior part of the glenoid is the most important part of the glenoid, as you know, regarding the Bankart lesions too. These are like bigger chunks of the bones. That's why we call glenoid fractures. If it causes instability, although it may be a smaller piece of bone, it may be an indication for surgery. Articular step-off, as I told you, is an articular, is a joint. When there's an articular step-off, a significant gap, this may be an indication. I don't know why this medialization doesn't show up, but medialization of the glenohumeral joint relative to the body or vice versa may be an indication. Glenopolar angle, I'm going to show you again the position of the glenoid. Angulation, the body, when it angulates significantly, it may cause problems in the scapula-thoracic motion, which has to be a good, in good terms, otherwise your shoulder doesn't work well. And superior shoulder suspensory complex. There are multiple breaks or tears around the shoulder. Sometimes it may become unstable. Here you go, the medialization shows up now. We usually get a CT with 3D recons. I think without the 3D recons, it's very hard to understand, especially the glenoid part. And looking at the axial, coronal, or sagittal views, I don't think it's a good idea to try to make a decision without a 3D recon. Again, articular step-off, as you can see in the axial CT cut for the glenoid is probably very helpful, how much step-off is in there. But you also need a kind of an en face view with subtraction of the proximal humerus to look at the glenoid, how much of the glenoid is involved and how much of displacement or gapping is in there. Again, there are multiple numbers, as you can see in the literature. The most common number coded is 3-4 millimeters, but in young healthy patients, that if I can think that I can reduce it better, I would operate on more than 2 millimeter displacements. Obviously, gap is better tolerated than step-off as anywhere else in the body. These are examples of the instability, and it involves different parts of the glenoid, as you can see in the 3D pictures down in there, and it can be in different patterns. It can be like a shark bite in the right lower hand corner, as you can see. Again, most important part is regarding the instability, anterior inferior part of the glenoid. So glenopolar angle. When the position of the glenoid part with a body fracture or glenoid neck fracture, if it kind of starts tilting down, it may affect the shoulder function. It has been kind of correlated with the poor function if it's less than 22 millimeters. Basically, what we are looking if the glenoid is tilting further downwards towards the floor. Medialization of the glenoid or the body relative to each other also has been correlated with some dysfunction because the rotator cuff muscles, which originates from the scapula and ends up in the proximal humerus, they are short distances. So if you shorten this distance furthermore, they may not function as well. And the body angulation, if it angulates 45 degrees, and we are not talking about 5-10 degrees, again, 45 degrees of angulation, I think the scapulothoracic joint may not be as happy. Superior shoulder suspensory complex is a kind of an interesting idea. There are multiple things can be injured, including some ligaments and the bones. If there are more than two things broken, you can assume that the shoulder is very unstable, but I think this is a little controversial because actually sometimes you can achieve the same outcome with non-operative treatment, so it does not necessarily always qualify for a surgical indication. The displacements needs to be significant. Again, I will probably use the primary displacements as an indication. This is a patient that I operated on through a posterior approach. This is a 62-year-old female after a motor vehicle accident, had a shoulder fracture dislocation, which was reduced at an outside hospital, and I referred to me 3 weeks later. On the x-rays first, you might think that it's not that terrible. There's some fracture in the inferior part of the glenoid, but when you get a CT scan in the axial cut, when you look at the glenoid in this young, healthy 62-year-old, there's a significant displacement involving half of the glenoid almost, and these are the CT scans. Again, the plane of the axial cuts also may make you think that the fracture pattern may be a little different. So with this one, again, involves the glenoid and mostly the body. I ended up operating on her, and she did very well. This is like 4.5 months post-op, and she got almost full range of motion. Another patient, again, through a posterior approach. This is a 30-year-old hairstylist that has to work, again, in this position most part of the day for work. She had this isolated injury. As you can see, the glenoid doesn't look happy. It involves the joint, and there are multiple parts involving the lower half of the glenoid. I think this requires surgery in a patient, in a young, healthy patient. This is a posterior approach through a classic Jude incision, but modified Jude approach through the intervals, not reflecting the whole infraspinatus. I used in this patient at that time, is a little older, a big boomerang plate that you can see here. I don't think you need big plates in scapula. You can use 2, 4 to 7 plates, and they are usually enough. She also did very well. I think these young, healthy patients, despite these wide exposures and wild exposures, they can do very well. This is 3 months follow-up for her. Limited posterior approach, when I will show you an example. As you can see, the skin incisions, these are like, instead of doing the classic big Jude approach that I will show you in the videos at the end of this session, smaller incisions on the medial and lateral border of the scapula and around the glenoid, you can fix these ones too, through a smaller incision. Deltopectoral approach is usually limited for the anterior inferior part of the glenoid. This is a 56-year-old male, fell off the scaffold at work, had multiple injuries. As you can see, the lungs doesn't look great neither. There's an inferior glenoid fracture. As you can see, I thought that this will cause more instability, and I ended up operating on him. This is his intra-op x-rays before the approach. This is after reducing and putting a lax screw first and putting a mini plate at the anterior inferior glenoid. He also had a non-displaced proximal gradiotuberosity fracture that I put some fixation to be able to start range of motion faster. And this is the final result. And he did well too. Again, the indications-wise, going back to the indications, the consensus about if there's any fracture in the glenoid that may cause an instability of the glenohumeral joint, may cause instability meaning subluxation or dislocation, or there's a significant step off of 3-4 millimeters. This is an indication for surgery. The other ones under the yellow box are more controversial: glenopolar angle, lateral border offset, body angulation, or multiple breaks around the shoulder. Thank you.